Thank you very much. It's truly a pleasure to be here to speak about neuroendocrine tumors to you all. So what I was going to do in the next 15, 20 minutes is sort of to give almost like a NET 101. And a lot of this you may know. I'm just going to try to put it sort of all together and maybe sort of set the stage for a number of really excellent speakers that will follow me that will go into much greater detail. So these are my disclosures, and I just wanted to start with by saying that when you are diagnosed with a neuroendocrine neoplasm, the question that always comes up is like, what are we dealing with? What is a neuroendocrine neoplasm or a neuroendocrine tumor or a neuroendocrine carcinoma? So even for us, for me, who's been in this for 20 plus years, I struggle with the sort of the naming of things. It's a complicated nomenclature. It seems to be changing all the time, and things that were called NETs one day and now called something else the next day. So hopefully I can shed some light on that and sort of explain some of the roles of different team members. So the nomenclature is really confusing, and sometimes go back to the classic literature on this. Humpty Dumpty, when he said, when I use a word, it means just what I choose it to mean, neither more nor less. And the question is really whether you can make words mean so many different things. And we've sort of gone through this with the neuroendocrine neoplasms and NETs a lot of times. Those of us have been doing this for long enough. We've seen a lot of changes, and it's not necessarily making things easier for us. So let's talk a little bit about the neuroendocrine neoplasms versus neuroendocrine tumors. So we know that we talk about neuroendocrine tumors all the time. We have our professional organization, the North American Neuroendocrine Tumor Society, but there's more. Neuroendocrine tumors really is a term for what we call well-differentiated, slower-growing malignancies. So what is the difference between NETs and NECs and NENs? So a NEN, a neuroendocrine neoplasm, is really the umbrella term that covers both neuroendocrine carcinomas, which are the more aggressive tumors, and the slower-growing neuroendocrine tumors. So what is a neoplasm? So a neoplasm is just an abnormal mass of tissue that results when cells divide more than they should, and they don't stop dividing, and they don't die when they should. And then a tumor is essentially the same, but when you have a carcinoma, then you have a growing clump of malignant cells that don't die when they should, and now they have the ability to invade other organs and spread to other parts of the body, and that's called carcinoma. So the NENS is really the most inclusive term that captures both the NETs and NECs. And I'm not sure if we should rename the Neuroendocrine Tumor Society. It's just NANENS just sounds weird. And not going to happen when I'm president. So it's so what are NENs? So NENs are neuroendocrine neoplasms or malignancies. These are cancers. So this is actually one thing that comes up all the time. Are these cancers or not? And they can arise almost anywhere in the body. I think I've seen them arise pretty much anywhere. But most commonly in the small intestines, lungs, pancreas, stomach, and rectum. And they're really heterogeneous. And what I mean there is that you can have tumors that behave in a strikingly different fashion from one person to the next. Even tumors that look the same in the microscope, look the same on the scan, behave very, very differently from one person to the next. And these tumors start from what we call neuroendocrine cells, which are widespread throughout our bodies. And sometimes something just goes wrong, and now they start growing or proliferating when they should not do that. So let's talk a little bit about the epidemiology of NENs and why I actually gave a very short talk today about why NENs are no longer rare disease. So I know that we like to think of these as rare tumors, but they are not, and becoming more common. And what I want to explain to you is the difference between incidence and prevalence. So incidence is really the number of new cases of a disease diagnosed in a given population over a certain period of time. So I'm from Rochester, Minnesota. We're about 100,000, and oftentimes the incidence is expressed as a number of new cases in a population of 100,000 in the course of 1 year. So I tell my patients that if the incidence is 3, that means that in Rochester, over a year, we diagnose 3 patients. So that's the incidence. The prevalence is really the number of patients who are dealing with the disease. So we use sometimes the bathtub analogy here. So the incidence is really what's coming out of the faucet. So that's the new cases. The prevalence is how much is in the bathtub. And some, sadly, will die from their disease. Others are cured, and they will then no longer. I'd actually say those who are cured are still at risk of recurrence, and they should probably be counted with the prevalence there. So the prevalence of is a much larger number than the incidence. So at any given time, there are very many patients with neuronic tumors. And this is how this has been going over the years. So if we look back, these are numbers from England. These are almost identical to the numbers we see from the US. So this goes back to 1995. And this is the incidence, so the number of new cases in Rochester, Minnesota, over a year, so, or in any population of 100,000. And you can see in the mid-90s, this is the number of new cases. See what's happening to all of these. So the blue line is lung. So this is more than like fourfold increase or more. And if you look at the green line, that's small bowel. The purple is appendix. The pancreas is the yellow line here. We actually looked at pancreatic neuronic tumors, and there is a threefold increase in the number of new pancreatic NETs over the last 20 years. And there's no way that this is becoming that much more common. I think what's happening is that we're just our scans are getting better. More centers are having scans. There's a lower threshold to get the scan. So someone slips on the ice in Rochester in January and goes into the emergency room, has a CT scan just to look for internal injuries, and they're found to have a tumor in the pancreas. So I think that actually explains a lot of this. This is from Norway, just looking at the incidence here. This is for the neuroendocrine tumors. You can see the incidence has really gone up for the well-differentiated neuroendocrine tumors, not so much for the poorly differentiated neuroendocrine carcinomas. And yeah, I could show you numbers from Taiwan. I could show you numbers from China or Japan or Iceland, for that matter. We actually have the two. And that's where I'm from. And all of these curves look the same. And this is just becoming much more common. So here, this is again from Norway. So looking at the incidence and number of new cases since the early 1990s until 2021. And you can see that this is getting a lot more common. These are the prevalence numbers. So this is the number of patients actually living with the disease, and look at how those have gone up. So we keep adding to the pool of patients, to the bathtub, and thankfully a lot more patients are living longer than ever. So that's why the number of patients actively dealing with this disease is increasing. And that's why we actually need more people to take care of you. And so that's that on the epidemiology. So let's move on to the pathology. I don't think we're going to have a lot of discussion of pathology. We have someone imaging here, so I'm going to move on. So the pathologist is obviously a very crucial part of the team. So they are needed to diagnose the neuroendocrine neoplasms correctly, and so we can treat them appropriately. If I don't have a good pathologist, I can really not give you the ideal treatment. So I am absolutely blind without a pathologist. So, and you have to have a pathologist you really trust, and this is not easy for many pathologists. A lot of these are very tough calls. Is it the neuroendocrine carcinoma, or is it the neuroendocrine tumor? And sometimes at institutions like mine, we end up having like 3 or 4 different pathologists take a look at the same slide. So what is tumor grade? So let's talk about tumor grade. So this is a system to predict how fast cancers will grow, and we use a tissue stain called KS7. So this is literally like ink. We apply it to a slide with little thin slice of tumor cells, and we count the number of cells that actually stain brown. And the more cells that stain brown, the higher the grade is. And this is how it looks to the pathologist. So on this side, we have grade 1. You see all of those light blue dots. So these are neuroendocrine tumor cells that are not growing. And the brown cells are those that stain positive for KS7. These cells are actively dividing. And as you go into the grade 2 and grade 3, you see more and more and more cells stain positive. So this is just a very good sort of reproducible way of grading the tumors. And the grade is a very, very strong predictor of how this tumor will behave. So we're all talking the same language here. So the tumor grade determines the aggressiveness. So NETs can be super slow, or they can be extremely fast. So I sometimes say the grade 1 tumors move incredibly slow at times. Sometimes you don't have to do anything for years, and you just watch them where they are slowly grow. or they can be extremely fast-growing. That would be the neuroendocrine carcinomas and some of the high-grade neuroendocrine, well-differentiated neuroendocrine tumors. They can move actually surprisingly fast, and sometimes they can move from a slow tumor growth to a fast tumor growth. It's called great transformation. So what about tumor differentiation? We heard that a lot too. So what is that? So that, the differentiation really tries to explain, or tries to, how different do the cancer cells look from the tissue they actually started in? So if they look sort of all the same, bland-looking, well-behaved, we call them well-differentiated, or do they look really aggressive? So do they look like they are up to nothing, or do they look super aggressive? And so as my wife's a pathologist, and one of her mentors said that these are cells that you would not want to meet in a dark alley at night. And so it's, and sometimes the pathologist, just by looking at them, can tell. So all poorly differentiated tumors are grade 3, but not all high-grade or grade 3 tumors are poorly differentiated. So we're going to have a talk on imaging, so I'm just going to go really quickly through this. All I will say is the imaging is really a team activity. So obviously crucial to have good radiologists who know what they're looking at, but it's equally crucial to have good equipment and good people, good technicians who actually do the scanning and make sure everything is done appropriately. So 3 main types of scans. I think we'll hear more about it here by one of our other speakers. The CT scan or the CAT scan is still the workhorse in the clinic. That's what I rely on the most. Those are everywhere, but they are kind of hard to do really well for neuroendocrine tumors. The MRI is really good for certain things, especially the liver. And then we have the PET scans we're going to hear more about. So the PET scans are coming 2, or now actually 3 or 4 different types. So one is called a somatostatin receptor PET, sometimes called a dotatate or a gallium or a copper PET. So that's looking at the expression of what's called somatostatin receptors on the surface of the tumor cells. I should actually include a picture of that next time. And then we have the FDG PET, which is what's called a metabolic PET that looks at the aggressiveness of the tumors. So this is just how it looks in the clinic to me. So this is a somatostatin receptor dotatate PET scan. We can see these red dots here. So these are tumors in the liver. This is what's called arterial phase CT, and this is venous phase CT. And what I wanted to show is that we see these little dots here that are much harder to see on the venous phase. And sometimes you just need, and this is a simple CT, and we need to pay really good attention to the timing of the contrast. So get the arterial phase, because that really lights up some of those tumors that you can't really see in the venous phase. So this is just an example of how important it is to have a person who actually does the scan correctly. Essentially, how important it is to have a really good technician. So, and then also wanted to point out that sometimes the tumors on the PET scans look a lot larger than they actually look in real life. There's a tiny little pancreatic neuron tumors that look really sort of threatening on the PET scan here. And then this is one of those somatostatin receptor PETs, so bone metastases, and this is how they grow over time, and now they're starting to involve a lot of the skeleton. This patient amazingly was completely asymptomatic with no bone pain at all, and got therapy, and is, to my knowledge, still doing quite well. So moving on, these are just some of those unusual metastases we see with neuroendocrine tumors, and sometimes they can go to strange places like the breast tissue, occasionally the brain, which you don't see very much. The small bowel neuroendocrine tumors sometimes go to the orbit, occasionally cause double vision that may have to be treated, and we're increasingly picking them up in the heart. And they don't seem to do any damage there. They just sit there quietly, and they rarely grow. So what is tumor stage, and who takes care of assigning the stage? So that's actually my job as a medical oncologist, is to look at all of the available information and decide on what the stage is, and I need scans, I need pathology, and sometimes operative reports and other procedure reports to do that, and this is how that works. So stage 0, we really rarely see in neuroendocrine tumor. Stage 1 and 2 are localized. Stage 3 is starting to go into the lymph nodes, and stage 4 is when it goes to other parts of the body. And that's how that looks. It's actually colon cancer. You can see here is stage 1 and 2. It's just sitting there in the colon. Stage 3 is now getting into the lymph nodes outside of the colon. Stage 4 is getting into, let's say, lungs and the liver. So I wanted to spend maybe the last 5 minutes on the NETRF and NETRF centers. So and the question is really, do I need to see a NETRF? And then actually, what is a NETRF anyway? And if they exist, how can I find them? And so there's really no standard definition of a net expert. We can actually debate this, and I actually think we should have some standards for that. So I'd say someone who sees a lot of neuronic tumor patients or neuronic neoplasm patients, but then the question is how much is a lot? And there's really no standard definition in the US for net expert center, but the Europeans have that. We have actually looked at doing this in the US, but we haven't done it yet. But net medicine is very complicated, multidisciplinary activity, so your entire team needs to be good. And your team, as I say, sometimes is only as good as the weakest link. If you don't have a good pathologist, well, the rest is going to be really, really hard. And how can you find a net expert center? So we have some lists, and NETRF has a list, some others have a list, and I think we can work on making these lists a little better than they are, but we do have some lists out there. And why would you see a net expert? Well, uncommon tumors, most oncologists don't have a whole lot of experience with this, they may not see that many. And then a net center may have access to clinical trials and advanced scans and advanced procedures. But not everyone needs to see a net expert at every visit. But I think everyone should see a net expert at some point in the journey, especially when there's a major change. Something is not going well, things are growing when they shouldn't be growing. That might be a good idea to go to your net expert. So the role of the net expert center is to confirm that the diagnosis is correct and the plan is good. So we see this all the time. This is pretty much all I do now. And then be available when at crucial time points, let's say when the tumors are growing, or if there are side effects or toxicities. And so I'm getting flagged for 5 minutes. I can stay within 5 minutes. So I think. And so anyway, so we'll move on. And so why tumor board? Well, what is a tumor board? The tumor board is essentially a meeting, can be in person or virtual, where we get all of these experts together in a room and we talk about the individual cases. Not everyone needs to be presented at tumor board at all times, but in challenging situations, especially at diagnosis, if we need to make a big decision regarding a big procedure or surgery, that's a good time to go to tumor board. So I usually say use the tumor board wisely. We don't want to bog the tumor board down discussing things that don't necessarily have to be discussed at tumor board, but when we really need to make crucial sort of multidisciplinary decisions, there is just nothing better than a good tumor board. And now actually we have some data that suggests that tumor boards improve the outcomes of treatment. So sort of just winding down here, so sometimes I think about it this way. So we have for a neuroendocrine neoplasm, we have a lot of different treatments. We have chemo and PRT and surgery and liver-directed therapy and targeted therapy. And let's say every treatment gives you like a certain amount of time. And if you add this all together, does it look something like this, or just the sum of those individual parts, or does it look something like that? So I actually think it looks like this. So when you play your cards wisely, so you have a number of cards and you play them wisely when you really have to, and then withhold cards when you don't have to play them, you might actually get a life expectancy or survival. It's much longer than each individual block. And that's the way I think about it often. And then the myeloids may vary, so from one person to the next. And everyone seems to be differently sensitive to different treatments. So that actually takes me to the end of the talk. So thanks to, obviously, all of you and all of the organizations and advocacy groups out there, all of the providers, especially those who don't get a lot of praise, X-ray technicians, desk staff, and things like that, and just all of the researchers out there. We're going to hear a lot more about research later tonight, but I think I'll just stop there. So that's for my hometown, Iceland, a little colder than Providence.